Hello, my name is Ian McCall, and this is the first of the webinars that we're doing in this advanced dermatology course. What I'd like to do now is just go through the website and show you some issues and how we're going to deal with this. First of all, if we're looking at these modules, each module is going to cover over a 2-week period these topics: a basic dermatology topic, surgical topic, dermatoscopy topic, histology topic, drug or treatment, clinical cases, an interesting journal article, and a tutorial topic. Now, there's going to be a registrar associated with each of the modules. And there'll be some questions that I want them just to do a little bit of research on beforehand. And these were some of the questions that I felt would be of relevance in this particular module. You know, what are the main cells in the epidermis and their functions? That's important. You got to know what the epidermis is made up of and what they do. Keratinocytes are a lot more versatile than simply the structure of the epidermis. They play an important part in our immune function. They play an important part in our protection from the outside world and from ultraviolet light. The second one there, what are the main proteins at the basement membrane relate then to the common blistering diseases? Well, you've got to know a little bit about the structure of the basement membrane. The autoimmune blistering diseases all involve cells and antibodies attacking specific antigens, or sometimes even groups of antigens, at the dermoepidermal junction. They inherited bullous diseases, epidermolysis bullosa. They all have defects in one or more of the proteins, again, that hold the layers of the dermis and the epidermis together. And there's the condition Hailey-Hailey disease, which is probably one of the commonest disorders that we're going to see, where the defect isn't at the dermoepidermal junction, but it is in fact in the bonds holding the keratinocytes together. We wanted to know a little bit about eccrine and apocrine sweat glands and how they differ, and we wanted to know a little bit about nerve endings in the skin. These are important. There are unmyelinated C fibers in the skin, and they are the nerve fibers that transmit the itch sensation. And itch is one of the major symptoms that patients with skin disease suffer from. So, let's have a little look at the basic dermatology topic here. It's the first part of the diploma course that we've run. And if you've had time, you should have been able to look at this particular video here and had a listen to the topic. Here's just a schematic representation of the epidermis itself. This little layer of basket weave stratum corneum, that represents 90% of the normal barrier function of the skin. So any process that causes loss of that stratum corneum is going to materially interfere with the normal protective layers. And it means that a patient can get an irritancy superimposed on whatever process they in fact have. So an irritant dermatitis can be superimposed on the hands if this layer is in fact lost. The dermal ridges, the dermal papillae here, and the epidermal retiridges here. The retiridges come down, the dermal papillae stick up. You'll come across the importance of the dermal papillae because of its blood supply. It's a structure where the layers, the number of cells, for instance, of melanocytes are thin here, relative to here. If you look vertically down here, you're going to have a whole series of melanocytes right down that retiridge there, and you're only going to have a single layer above a dermal papillae here, and that gives rise to the net-like pattern that you see with the dermatoscope. This just looked at some of the adnexal structures that are in the skin. The hair follicles are obviously of importance. They are particularly of importance because of the stem cells that they contain. And these stem cells, particularly around this area here, the lower part of the infundibulum, the bulge area, these stem cells are very important in replenishing some of the cells in the epidermis itself. This, by the way, was a condition called erythema annulare centrifugum. Here you have this trailing scale. EAC is one of the annular erythemas, and the next thing we go on to is the mnemonics that we use in the diagnosis of skin disease. And you'll find that annular erythemas come in both the red scaly and the red non-scaly diseases, because some of them have a trailing scale like this, and some of the annular erythemas are just red with a smooth skin and expanding edge. I'd hoped you might have had a chance to look at this particular video here. It's from Habib's book, and it looks at his interpretation of regional diagnosis. I think it's one of the ways in which we help to diagnose skin diseases, simply the fact that certain diseases occur more commonly in certain areas. And Habib does quite a nice section on the common diseases occurring in certain areas. Worth looking at that video. This is a picture of immunofluorescence at the base of the epidermis. Immunofluorescence is a technique that's used to determine if any antibodies have been deposited at the dermo-epidermal junction, or sometimes even within the epidermis itself. And fluorescent technique is used to show this deposition. So it's an antibody with an anti-antibody with a fluorescing molecule attached to it that shows up like this. And this is the deposition of IgG and C3 at the dermo-epidermal junction that you see in bullous pemphigoid. You'll find that immunofluorescence, direct immunofluorescence, is a technique that's essential to the diagnosis of many of the blistering skin diseases. Now, this was looking at skin diagnosis. And the important thing here, I've said, how do you go about diagnosing a skin rash? I said there are over 2,000 named skin diseases. But one technique I've found very useful is to ask yourself 3 questions and to learn 4 mnemonics. And the 3 questions are, is the rash skin-colored or red, and is it scaly or non-scaly? Second question, are there any pustules or blisters? The third question, is the rash in a funny shape, color, or distribution? And the 4 mnemonics, well, the vast majority of skin diseases, inflammatory skin diseases you're going to see, are going to be red and scaly or red and non-scaly. This is the mnemonic for the red scaly diseases, the PM's pet. It's a little cat called Petal. I used to think of Kevin Rudd sitting with a little Siamese cat in his lap. So the PM's pet, Petal. And PETEL, psoriasis, eczema, tinea, annular erythema, and the L can stand for lupus, especially discoid type, for lichen planus, for some forms of polymorphous light eruption, for pityriasis lichenoides, for Lewy or syphilis, can give a red scaly disorder. The initial P of PMs is pityriasis rosea, pityriasis versicolor, pityriasis rubripilaris, pityriasis lichenoides. They're all red scaly diseases. The M is for mycosis fungoides, T-cell lymphoma, and the little S is for solar damage, because solar damage is quite a common cause of red scaly diseases. Some people in Australia just have very extensive solar damage. S can also stand for scabies, because some scabetic rashes will be red and scaly as well. What about the red non-scaly ones? See you later at the Department of Veteran Affairs, Evie. Evie's your girlfriend. So see you later at the Department of Veterans Affairs, Evie. The C was for cellulitis, the U for urticaria, the L, again, for lichen planus. For lupus erythematosus, particularly subacute and systemic lupus, because it's red and non-scaly. Some light eruptions will come in there. DVA, drugs, viral or bacterial exanthems, and again the annular erythemas, because some of them are red and non-scaly. Erythema chronicum migrans, some forms of erythema annularis centrifugum. And then E. E for erythema multiforme, V for vasculitis, I for infiltrates, and E for erythema nodosum. Pustular diseases, II, infective or inflammatory. And inflammatory is usually either drug or psoriasis. Infective can be viral, bacterial, or fungal. Blistering diseases, ICI. Again, infective, viral, bacterial, or fungal. C for contact dermatitis, and I for both inflammatory and immunological. So inflammatory blistering diseases, again, can be drugs, can be insect bite reaction, can be polycythemia, can be porphyria cutanea tarda. And the immunological, well, is the range of the immunological blistering diseases. So the various websites here can be used to go through this further. This again was just a description of the approach to the red scaly diseases. So those are the main dermatology things to have looked at in this particular module. Now, what about dermatoscopy topics? We said that the material here is taken from the dermatoscopy diploma course and also from the Dermatoscopy Made Simple website. Correct word is dermatoscopy rather than dermoscopy, but dermoscopy has been used for a while. It's taking a wee while to change it. Initially, we're going to look at structures and colors. Now, I alluded earlier on to the net-like pattern that you see in the epidermis with a dermatoscope being due to the holes being due to the very thin layer of melanocytes that are on the top of a dermal papilla, and the edges of the net being due to the thick layer of cells that you're seeing looking vertically down the edge of a Rete ridge. The presence of a network does not necessarily mean that the lesion is melanocytic. You can get networks in non-melanocytic lesions. Have a look at this video. It goes through a description of the issues with various structures and colors. And also have a look at the Dermoscopy Made Simple website. The issue of colors. Well, the colors that you're going to see with the dermatoscope, they're usually due to melanin, and whether it's black or brown or gray or blue depends on where the melanin is in the skin. If it's high up in the skin underneath the stratum corneum, it's going to look black. If it's at the dermoepidermal junction, it's going to be a light brown. If it's in the dermis, the upper dermis, it's going to be gray. And if it's in the deeper dermis, it's going to be blue, as in a blue nevus. But colors are also due to blood, and it gives red, pink, purple, and black colors. And you also get white, and that's due to fibrosis or scarring in the skin. Get a bit of yellow too, and orange, which is due to keratin, and you'll see that mainly in some seborrheic keratoses. So, we've commented already about melanin and the color it's going to appear. We've talked about some of the non-melanin colors as well, the pinks, the whites, the yellows, and the orange. This was just a good image of an amelanotic melanoma that had arisen beside a pigmented lesion. This was an amelanotic focus. There were some white lines within this and a milky pink color as well. The vague pigmentary network in this area here. There are other structures that you're going to see with your dermatoscope, and these include dots and globules. We like to call these clods. Generally, these refer to nests of cells. And you tend to see them more towards the edge of a pigmented lesion because that's where you're getting your proliferating nests of cells. There's a little video there on dots, a video on clods. You can have streaks as well. We tend to call these lines radioperipheral now. And these again represent rapidly growing nests of cells. Multiple streaks symmetrically all around the lesion are likely to make it a Reed nevus. Here's another one here, though, that as well as having radial streaks, has little bulbs on the end of the streaks, and these are called pseudopods. Now, provided they're symmetrical like this right round the lesion, then it's suggestive of a Reed's nevus. If it was only localized in certain areas and not found elsewhere, then it would be more suggestive of a melanoma. So asymmetrical pseudopods are more suggestive of a melanoma. So have a good look through this issue on structures and colors. Have a look at the videos that are there. It'll certainly give you a greater understanding of what's going to be involved in this module. The treatment topic we wanted to look at, well, it was topical steroids. We'll discuss these during the module itself, during the webinar. Topical steroids are the linchpin of treatment of many of the inflammatory skin diseases. But there's a lot of misinformation out there on topical steroids. You have to learn how to use them, and it's important that you use them selectively for fixed periods of time, and you select the appropriate topical steroid both for the severity of the condition and for the site at which you're applying it. And in the webinar we'll talk in a little bit more detail about the topical steroids themselves, the different molecules that are involved, the development of tachyphylaxis, the whole problem of compliance with applying these medications, and complications that can occur in different areas. And then lastly, clinical cases. We'll have a look at some. There's this case of acrodermatitis continua of Halle-Prouot. This is a form of localized pustular psoriasis that occurs acrally, and we'll certainly have a little look at that particular case. And if there are some other good cases put up in the virtual clinical meeting, we'll look at those. So just having a quick look at acrodermatitis of Halle-Prouot. Localized pustules, tip of a finger. It's only one finger you consider that it might be localized herpes simplex as well. So you'd always take both viral and bacterial swabs here. But often this involves under the nail as well, and the nail will lift and sometimes come off, and there's often quite a marked sort of paronychia picture. So it looks infective, but this is really inflammatory. There isn't any bacterial infection here. Excuse me. So have a little look at this. There should be a video on this. I think I did as well. If you've got time, have a little listen to the video as well. Okay, that's an overview of this particular module. These are the things I want you to try and concentrate on if you can. And I hope that's been of some value in directing you what to look at. Thank you very much.